So now I'm going to start with my pre-procedural steps. First thing is to check the nursing care plan, gather any supplies that will be needed, wash my hands, then enter the patient's room, introduce myself, and get 2 separate patient identifiers, their name and their date of birth. Then I would provide privacy, explain what I'm going to be doing, and then lower the bed or raise the bed to the appropriate height. So today I'll be doing neurological, cardiovascular, peripherovascular, neurovascular, respiratory, and abdominal assessment of the patient. So I'm going to start with my neurological assessment. First thing I will do is note the patient's appearance. I would note that the patient is appropriately dressed, well groomed, and then I would note their behavior, that they are behaving appropriate for the situation and appear to be normal. Then I'll move on to my JOMACs, starting with their judgment. I'll ask my patient what they would do in the case of a fire, and then I would ask them of any future goals they have, such as what are your plans after you graduate from Marian University. Then I'll move on to orientation, making sure that my patient is oriented to person, place, time, and situation. So for person, I would ask them who is the president, and then make sure that they had the appropriate response. For place, I would ask them, where are you right now? Time, I would say about what time of day is it right now? And then situation, I would say, what is your reason for coming in to see me today? So after I've evaluated the orientation, I will move on to memory. I will start with getting my saying a phrase to my patient and having them repeat the phrase back to me to test their immediate recall. Then I will ask them what the weather was like yesterday to test their intermediate recall, and then I would ask them when is their birthday to test their long-term recall. Next, I will move on to their appearance. So I would note that attention. So I will note that the patient is appropriately is giving me appropriate attention, is able to pay attention to the instructions that I'm giving them, and maintains proper eye contact, and they appear alert. And then finally, I will move on to their cognition. And to do this, I will throughout my initial assessment, I am evaluating their cognition, making sure that their thought processes seem logical, coherent, that their speech is fluent, and well, that's actually the last one. The S, and for JOMACs, I will move on to evaluating their speech. I would actually be doing this during the entire first part of the assessment, just making sure that it is clear, coherent, and it is appropriately rhythmic. There's no abnormalities there. So after I've done my JOMACs assessment, I'll move on to assessing my patient's cranial nerves, starting with cranial nerve 1, which is the olfactory nerve. So to do this, I would have my patient plug one nostril, and then have a cotton ball with alcohol on it, and I would raise the cotton ball to their nostril, have them breathe in, and then tell me what they smell. And then I'll do this with both nostrils to make sure that cranial nerve 1 is intact and functioning properly. Then I'll move on to cranial nerve 2, which is the optic nerve. And for this, I would test this with Perla. So as I did before my eye exam, I place my hand in the middle of their eyes, and I want to bring my light in front of the pupil. First time watching the right eye, and the second time watching the left eye, to make sure that they're they're round, reactive to light, and accommodating appropriately. And they are, so I can note that my patient's cranial nerve number 2 is intact and functioning properly. And then I'll move on to assessing cranial nerve number 3, 4, and 6, which is the oculomotor, the abducens, and then the trochlear. And to assess this, I will do the 6 cardinal gazes. So I'll instruct my patient to keep your head still and watch the end of my pen and just follow with your eyes. So 1, 2, 3, 4, 5, 6. So I note that the eyes are following my pen properly and they do have all 6 cardinal gazes. Oh, additionally, when I'm evaluating the cranial nerve number 2, I would also check to make sure that the red reflex is intact while I am evaluating the pupils for Perla. So now I'll move on to number 5, which is the tegmental nerve, which functions with the jaw clenching. So what I would do is get behind my patient, place my hand on their jaw, and have them clench their teeth, and then also open and close their mouth, testing to see if there's any kind of crepitus or TMJ, and there's not, so I can note that cranial nerve number 5 is intact. And then I'll move on to cranial nerve number 7, which is the facial cranial nerve. So to test this, I'll have my patient smile. Will you smile for me? Frown. Show me your teeth. And then open their mouth and close their mouth. Oh, actually, raise your eyebrows and lower your eyebrows. There we go. So I will note that cranial nerve number 7 is functioning properly and intact. So I can move on to cranial nerve number 8. Cranial nerve number 8 is the acoustic cranial nerve. So I will check my patient's hearing by doing the whisper test. So if you please plug your right ear for me and then repeat this phrase after me.
1, 2, 3.
Okay, now plug your other ear. Repeat this phrase.
A, B, C. A, B, C.
Okay, so I note that my patient's hearing is intact and that the cranial nerve number 8 is functioning properly. Now I will move on to assessing cranial nerves number 9 and 10, which is the glossopharyngeal and the valgus cranial nerve. So to do this, I have my patient open their mouth, say ah, and inspect inside the mouth. So please open your mouth and say ah.
Ah.
Okay, and what I'm looking to see is that the uvula is midline and the palate is rising and falling as they're saying I, and it is midline and everything is symmetrical. So I note that cranial nerves number 9 and 10 are also intact. So now I'll move on to cranial nerve number 11, which is the spinal accessory nerve. So the way I would assess this is I'll instruct my patient, please raise your shoulders and don't let me push down. Okay? And then if you rotate your neck around for me, just noting that that their spinal accessory nerve is intact and functioning properly. And finally, I move on to cranial nerve number 12, which is the hypoglossal nerve. And to test this, I would have my patient stick your tongue out for me, and then repeat the phrase tit, tat, tint.
Tit, tat, tint.
Making sure that they're perfectly able to hit those T's and that their tongue is fully functional. So once I've assessed the cranial nerves, I can then move on to testing their sensory function. So the first thing I'll assess is the pain sensation. So I guess I'll use my pin light. So I'll have the patient hold out their arm, and I will touch their arm with something dull and have them tell me if they feel that sensation. And then I would have something sharp, maybe like a pin or something where I could also test their sensation for sharp pain. And then I will move on to assessing their light touch sensation. So I would have the patient close their eyes. Close your eyes, please. And I would take a cotton ball, and I would touch it somewhere on their body, either their face, their cheek, or also could be their arm, and then just have them identify when I'm touching them and that they do feel the sensation. So, and for my final part of my neurological assessment, I will test my patient's reflexes. So I will first test the patellar reflex. I would have a reflex hammer I would instruct my patient to straighten out their knee slightly, or bend slightly, sorry. And then I would just tap with the hammer right at the bend of their knee and make sure that I get a proper reflex. And I would do this on both knees. So just to make sure that that reflex is intact. And then I move on to the plantar reflex. And this is where we're testing for the Babinski sign. So I would take the back end of my reflex hammer and come up the patient's foot. And I would note that the toes should curl down. They should not spread out. That would be, if they spread out, it would be a positive Babinski sign, and that is not what we want to see. So I would perform this on both feet as well, just to make sure that my patient is negative for the Babinski sign. So the last part of the assessment, I would perform a Romberg test on my patient. So I would have the patient stand up and close their eyes, and to check to see that they can maintain their balance properly and there's no swaying or moving back and forth. You're good. So, and I would note that the patient had a negative Romberg test. And then I would also test the rapid movement of their extremity. So to do this, I would have my patient touch their finger, each one of their fingers to their thumb in a rapid movement like that, just to make sure that that function is proper and intact. And in a normal neurological examination, we may also examine the strength of their extremities, but this has already been performed in the musculoskeletal assessment, so it's not necessary here. So now we're going to move on to the cardiac assessment, or cardiovascular assessment. The first thing I'm going to do is to inspect my patient, make sure that their chest is symmetrical, there are no lesions or edema or scars that are visible, no masses or deformities. And then I will inspect and note where the heart is at. That on the right side. The right side is posterior, or it's anterior, and the left side is posterior. And then I will note that the base of the heart is located at the right sternal border, and then the apex is at the fifth intercostal space at the mid-clavicular line. So once I have completed my inspection, I can move on to my auscultation. I'll auscultate the aortic, pulmonary, Erb's point, tricuspid, and mitral pulses. And when I'm listening for the different heart sounds in this. So for the aortic, I want to hear S2. Pulmonary, I also want to hear S2. Tricuspid, or Erb's point, I should hear S1 and S2. Tricuspid, I should hear S1, and mitral, I should hear S1 as well. So I will start my auscultation. At the aortic site, which is the second right intercostal space. Checking for S2. Then I'll move over to the pulmonic, which is at the left second intercostal space. Then I'm also checking for S2 here as well. Then I will move down to Erb's point, which is at the third intercostal, right third intercostal space, checking for S1 and S2. And then I will move down to the tricuspid, to the tricuspid, which should be at the fourth left intercostal space, noting for S1, or listening for S1. And then I will move to the fifth intercostal space, fifth left intercostal space, to listen to the mitral sound. And here I should hear S1 as well. So I note that all of the heart sounds are present and are appropriate for the patient. S1 sounds is the closing of the AV valves, atrioventricular valves, and S2 represents the closing of the semilunar valves. So once I've completed that auscultation of the cardiovascular system, I can move on to the peripheral vascular system. So what I'm going to do for this is to palpate the different pulses on my patient to make sure that they are +2 and regular. And so I will start with the carotid pulse, doing one side at a time, checking to make sure it is appropriate and +2. And it is. Then I'll move on to the brachial pulse, which will be palpated here. Then I'll move on to the radial pulse. Then the femoral pulse, which we're not going to palpate on our patient, but it is located right here. Then I will move on to the popliteal pulse, which can be palpated behind the patient's knee. And then finally I'll move on to the dorsal pulse. Not finally, there's one more. The dorsal pulse, which can be palpated on the top of the patient's foot. And then the final pulse is on the interior, the medial side of the patient's ankle. And I note that all those pulses are present and +2. And so that that will complete my assessment of the pulses. And then while I'm doing this, I'm also assessing for any edema, making sure that there is no edema. And then I can also check the patient's capillary refill, making sure that color returns to their nails under 3 seconds. And that will complete my peripheral vascular assessment. And I can move on to the neurovascular assessment, which is based on the 5 Ps: power, pulse, pain, numbness, or paresthesis, and paralysis. So for power, I just note that my patient's color is appropriate for their race and ethnicity. For their pulses, I just checked their pulses and noted that they were all +2 and normal. I'll ask my patient if they're having any pain, and then if they're having any paresthesis, which is numbness or tingling in any of their extremities, and then also paralysis. I would be able to note, it would have been apparent earlier on in my assessment that the patient is suffering from any sort of paralysis. So this will conclude my cardiovascular, neurovascular, peripheral vascular assessment, and now we can move on to assessment of the respiratory system. So now I'm going to move on to the assessment of the respiratory system, starting with inspection. I'm going to inspect the patient anterior and posteriorly to make sure their chest is symmetrical, that there's no masses or lesions that are apparent, and then I'm also going to note that on the patient's right side, the lung has 3 lobes, the upper, middle, and lower lobe, and on the left side there's only 2 lobes, the superior and inferior lobe, and this is because of the location of the heart. During my inspection, I'll also measure the AP diameter with my stethoscope, noting that anterior and posterior chest width is at least 2 times as wide as the depth of the patient's chest. Once I've done this, during this inspection, I'm also assessing the patient to make sure that they're not having any labored breathing, there's no nasal flaring, no tripoding, no use of accessory muscles, that their respiratory rate is normal and their breathing is rhythmic. So once I've completed this inspection, I can then move on to the auscultation of the patient. So on their anterior side, I'm going to be auscultating in 5 different areas and making sure to stay towards the center of the chest so that way I avoid breast tissue. And on a normal patient, we would want to have our stethoscope directly on the patient's skin. We may have them remove their shirt, but for this purpose, we're not doing that. So at each of the 5 locations, I will make sure that I wait for 1 complete inspiration and 1 expiration before I move on to the next location. So I'm just listening to make sure that the patient has normal breathing sounds and there's no adventitious sounds, rales, rhonchi, wheezing, anything such as this. And now I've completed the anterior auscultation. I can move on to posterior. So on the posterior auscultation, I'll be auscultating at 9 different sites. Again, waiting for one entire respiration, inhalation, and exhalation before moving on to the next location. So here we go. So again, just listening to make sure that there are normal breath sounds and there's no adventitious sounds such as rales, bronchi, or wheezing. So after I've completed the auscultation, I can move on to palpation. I want to hear or feel resonance over the lung tissue, and it will be a dull sound produced over any bone or fluid-filled organs. So in the same locations that I auscultated, I'll now palpate. Okay, so I note that the lung tissue did produce proper resonance, and it was appropriate, and there was a proper response. So now I can move on to checking for tactile fremitus, and to do this, I will have my patient say 99 as I'm checking in on the same 9 locations that I've auscultated and palpated, or auscultated and percussed. I'm now palpating. Checking to see, make sure there's no fluid in the lungs, so I should feel a vibration each time they say 99. So just say 99 for me.
99, 99, 99, 99, 99, 99, 99, 99, 99, 99, 99, 99, 99, 99, 99, 99, 99.
Okay, so I note that there was no presence of tactile fremitus, so this indicates that the patient does not have fluid in the lungs. And then finally, I'm going to just simply palpate both the posterior and the anterior chest, just making sure that there's no tenderness and the patient isn't experiencing any pain, no tenderness or edema for the patient. And then finally, I will check the patient's chest expansion. I'll place my hands on their side and have them inhale and exhale. And as they're inhaling, my hands should expand with their lungs and should come back in as they exhale. So this will complete my assessment of the respiratory system, and now we can move on to the abdomen. So now we'll move on to our abdominal assessment. The first thing I do is have my patient lie down, bend their knees, just to make sure they're comfortable. And I'll take care to provide them proper privacy and only expose the area that is being inspected. So I'll expose the abdomen area. And for the abdomen, when I'm inspecting it, I want to note that it is flat, it is free of lesions, edema, scars, and it is symmetrical. So the first thing for the abdomen that we want to do is we want to auscultate, because we want to do this for percussion and palpation, because we don't want to induce any kind of bowel sounds that may may not be there normally. So we want to listen before we move on to anything. And we want to start at the right lower quadrant because this is the opening of the ileocecal valve. And it is also, this is also the location of the appendix. But what we want to do is we want to listen and see if there is a normal active bowel sounds, a hyperactive or hypoactive. If it's normal, we should have about 10 to 30 bowel sounds per minute. So when I'm auscultating, I'll auscultate for 10 or 15 seconds and then multiply that by 4 to estimate how many bowel sounds that would be per minute. So we want there to be low pitch sounds in the abdomen. This would indicate normal bowel sounds. And then, so we'll move on to so we'll go ahead and do the auscultation of the patient, starting in the right lower quadrant. Then move up to the right upper quadrant. In the left upper quadrant. In the left lower quadrant. And I would note that my patient does have normal active bowel sounds, and they're low pitched and appropriate. So now I can move on to the percussion. So I want to hear, when I'm percussing the patient's abdomen, I'll start in the right lower quadrant. And I want there to be timpani sounds. These are high-pitched sounds. And then there should be dullness would only occur if it was over a fluid-filled organ or over bone. So I'll start. And I note that upon percussion, the sounds, it did produce tympanic sounds, and they were appropriate for the patient. So now I can move on to the palpation of the patient, starting in the right lower quadrant. Here is where you'll find the cecum and the appendix, 2 landmarks that you can find there. And then I'll move to the right upper quadrant, and here's where you can find the liver and also the head of the pancreas and the right kidney. And then I'll move on to the left upper quadrant, where you would find the left kidney and the stomach. And then I'll move on to the left lower quadrant, where we find part of the descending colon and the sigmoid colon. So when I'm palpating, I should not be able to feel any of these organs. That would indicate that something abnormal is going on. So want to palpate gently to not upset the patient. And I note that none of the organs are palpable, and the abdomen is soft and appropriate for the patient. So now finally, I will move on to the costovertebral angle, checking for the kidneys, see if there's any tenderness in the kidneys. So for this, I would have my patient sit up, and I would place my hand on the kidney and tap with a fist. Is that any tenderness?
Nope.
Okay, and then I'll move on to the other side. Tap with a fist. Tenderness?
Nope.
Okay, so I note that there is no renal tenderness, and this is appropriate for the patient. So that will complete my assessment of the abdominal area, and will complete this assessment of neurological, cardiovascular, neurovascular, peripheral vascular, respiratory, and abdominal. For my post-procedural steps, first thing I will do is lower the patient's bed back down to the lowest locking height and raise the guardrails. Make sure that their call light is within reach. I would then reassess the patient, make sure there's nothing else they need or there's no further questions that they have for me, I will tell the patient when I plan to return, and then as I'm leaving, I will dispose of any PPE that I had on, and then I'll clean any equipment that was used during the assessment, wash my hands, and then properly document everything that was assessed during my check on the patient.